So good morning, everybody. Today's topic is about the cranial nerves, which is very important topic and very extensive topics. And I hope in these 2.5 hours we can finish it and say the more and the most basic information about that. As you know from the first semester, when you study the skull, you know that we have 12 pairs cranial nerve. And they are, as a matter of fact, there are 13. In a while I will tell you why. And they have the coarse intracranial course and extracranial course. The course that they are passing intracranial, it means that they are passing inside the skull, and extracranial when they are exit from the skull, from the different opening of the skull that in the first semester you have studied. Then the pathway of the cranial nerve, they have the pathway through the central nervous system and the pathway through the peripheral nervous system as a peripheral nervous system. The central nervous system, the nuclei from the different fiber of the cranial nerve, they are located inside the brain, mostly in the brainstem. That in a while we will discuss. And also from this nuclei, the cranial nerve, they are starting. If it is efferent, it's starting, and if it is afferent, they are ending. Then the passage of the pathway of the cranial nerve inside the central nervous system, it's their connection with the different part of the central nervous system. For example, most important is cortex, that you will see it in the lecture, and their projection and connection between the different part of the central nervous system. And I have to say also about the retina, maybe you know it from the first semester about the eye lecture, that the retina, as a matter of fact, is a part of the central nervous system. And inside the retina, there are some cells that the optic pathway or visual pathway is starting. And that's why the third neuron that we are going to discuss, as a matter of fact, the axons of the third neurons, they are forming the optic nerve. So retina and optic nerve, as a matter of fact, they are part of the central nervous system as well. So then the course of the cranial nerve through the, after that it exiting from the central nervous system, they are the peripheral part. It means that we have the sensory ending for the afferent fiber with their ganglion. Usually this ganglion, they are intracranially located. For example, the ganglion of the trigeminal nerve, as you know, that is located in the impression of the ganglion of the cranial nerve. It means that in the apex of the petrosal part, or geniculate ganglion of the facial nerve, or the ganglions of the glossopharyngeal and vagus that we are going to discuss. Those are the sensory ending or afferent fiber which are synapsing inside the ganglion. And then we have some cranial nerve. They have somatomotor and branchiomotor that in a while we are discussing. Usually they don't have ganglion, though. They are starting from the motor nucleus in the central nervous system, and they reach to the effector organ, which are, for the case of the somatomotor, they are the skeletal muscles. The next fiber, they are visceromotor. Be careful whenever you see or you heard about the visceromotor or visceroefferent or viscerosecretor. We are talking about the parasympathetic fiber. So visceromotor is synonymous with the parasympathetic fiber. And of course, during the lecture, you have heard several times about the parasympathetic ganglion, that there are 4. which is related to this parasympathetic fiber or visceromotoric fiber, and those ganglion, they are otic ganglion, ciliary ganglion, pterygopalatine ganglion, and the submandibular ganglion. And usually they are located outside of the skull, so they are interconnecting with the pre- and post-ganglionic fiber inside the ganglion, and the location of this ganglion, it's outside of the skull usually. For example, you know, in the pterygopalatine fossa, pterygopalatine ganglion, in infratemporal fossa, which ganglion we can find? Yes? In infratemporal fossa, which ganglion we can find? Otic ganglion, perfect. And then in submandibular region, submandibular ganglion and ciliary ganglion, it's located in the retrobulbar space that we are going to discuss about that. So what is important about the cranial nerve? What you know, what you have to know, it's of course the name and number of the cranial nerve that already you know. Then you have to know the place of the exit from the brainstem. So the cranial nerve, each cranial nerve is exiting from the different part of the central nervous system, mainly the brainstem, except first and second cranial nerve that we are going to discuss, that they are not a true cranial nerve. Then you have to know the name of the nucleus and the types of the fiber. Some cranial fiber, they are exclusively, for example, motoric. They have motoric fiber. The other cranial nerve, they are pure sensory, or there are some of the cranial nerve, they are mixed. So you have to know each cranial nerve, it contains what kind of fiber. And the origin of this fiber is from which nucleus. And this nucleus is located in which part of the central nervous system, which is very important. Then, of course, you know, you have to know the pathway of this cranial nerve. Where does it pass? For example, how it exits from the skull, that you know it from the first semester in the exam of the skull, different opening of the skull, different cranial nerve is passing through that. Then some of the, or most of the cranial nerve, of course, they gives branches, and each branches, again, they contain some kind of the fiber. So some of them, they are pure somatomotoric, some of them, they are pure sensory fiber, and so on, that one by one we are going to discuss. And finally, you have to know the function of these fibers. So if there is motoric or somatomotoric, is innervating which muscle and what is the action of the or function of this muscle. If it is the sensory or general sensation fiber they have, so which area of the body is innervated by this cranial nerve and the region of the innervation. So those are the, for a study of the cranial nerve, you have to focus to those parameters that is written here. This is the recapitulation of the, or summary of the name of the cranial nerve that definitely till now or by now you know. There are the 12 cranial nerve here. As I said, that usually is not mentioned in the anatomical textbook. We have the another cranial nerve that sometimes they call it cranial nerve number 0. And its name is the terminal nerve in English terminology. And in the human being is rudimentary. So it's still they are discussing about the function of this nerve, and usually in dissection you don't, if you are not careful, so you cannot dissect it, but in careful dissection sometimes you can see this terminal nerve or cranial nerve number 0 that in a while I'm going to discuss it, and usually they are more developed this nerve in animals, mainly in reptiles, especially snake or cats or horse, for example. So they are much more developed, but in human being it still is not the function, it's clear, but of course it somehow is related to the, maybe it's related to the discussion that is related to the olfactory or the sense of the smell and the perception of some chemoreceptor or chemicals, molecules in the mouth and nasal cavity that I'm going to discuss. So those are the list of the cranial nerve: olfactory nerve number 1, optic nerve number 2, oculomotor nerve 3, trochlear nerve 4, trigeminal nerve 5, which is further is divided to the 3 branch V1, V2, V3. V1 is ophthalmic, V2 maxillary, and V3 mandibular nerve. Those are the 3 branches. Then abducens nerve 6, facial, 7, vestibulocochlear, 8, glossopharyngeal nerve, vagus nerve, which is the longest cranial nerve, and as a matter of fact, the longest parasympathetic nerve of your body, which is the cranial nerve number 10. Do you know where the territory of the vagus is finishing? In abdomen. The vagus is starting from the brainstem, the central nervous system, and is passing through the head, neck, it entering to the thorax. As you know, it's perforating the diaphragm via the esophageal hiatus. It's entering to the abdomen, and somewhere in the abdomen, the territory is finishing. Yes, Moritz. Exactly, not exactly transverse colon is the location of the splenic colic flexure. It's the transition place between the transverse colon and descending colon. So the left colic flexure or splenic colic flexure, it's the points that the territory of the vagus is finishing, and the rest of the parasympathetic part of your body is under the influence of the parasympathetic part of the sacral plexus from S2 till S4 segment of the sacral plexus. So, of course, we are going to discuss the accessory nerve 11 and hypoglossal nerve. So those are the number and the name, which is the easy, and already you know it from the first semester. Then, of course, you have to find this cranial nerve in the brain, in the central nervous system. Where are the location or where are the exit of this cranial nerve from the brain stem, except the first 2, and how they pass through the opening of the skull. That, as a matter of fact, you did the exam about the opening of the skull and what the structure is passing. So here, as you see, it's the olfactory bulb. It's continue as a olfactory tract. It's is related to the cranial nerve number 1. It's cranial nerve number 1. Be careful; they are not true cranial nerve. They are a part of the central nervous system, and as we are going to discuss, the olfactory nerve, cranial nerve number 1, is a part of the telencephalon. So it's a part of the central nervous system. Optic nerve, cranial nerve number 2, also is not a true cranial nerve, is a part of the central nervous system, which is called diencephalon. The real or true cranial nerve, as a matter of fact, is starting from the oculomotor nerve, which is arising from brain stem, respectively the midbrain or mesencephalon. In this place between the 2 peduncle or the crus of the mesencephalon or midbrain. That's why this area is called the interpeduncular fossa, which is the place of the exiting of the oculomotor nerve from the mesencephalon or brain stem. Further, you see the trochlear nerve we are going to discuss is the only cranial nerve that is arising from the dorsal aspect of the brain stem. All the cranial nerve is arising from the ventral aspect of the brain stem, which is composed of medulla oblongata, pons vareoli and mesencephalon. And the exception is this trochlear nerve, which is the thinnest cranial nerve and is arising from the dorsal aspect of the mesencephalon below the inferior colliculus. So this is the trochlear nerve, and of course then it's the trigeminal nerve, which is the biggest and largest cranial nerve of your, the cranial nerve is arising from the anterolateral aspect of the pons vareoli, and then is further is divided to the ophthalmic branch, maxillary branch, and mandibular branch, which is the, again, larger one, V1, V2, V3. And we are going to discuss very important part and a small portion of the trigeminal nerve is this nerve that you can see it in all picture about the trigeminal nerve. And we are going to discuss that this trigeminal nerve, as a matter of fact, is mainly sensory. It has a sensory function. So the larger portion of the trigeminal nerve is responsible for the sensory or afferent innervation of the different part of the face region and head region that we are going to discuss. And this small part that is passing here, it's the motoric portion, is called or portio motorica, or the minor portion or the lesser portion of the trigeminal nerve, that only it goes to the, again I'm repeating, only it goes to the mandibular branch of the trigeminal nerve. It means that ophthalmic and maxillary, the V1, V2, they are pure sensory or sensitive nerve. And the mandibular nerve, in addition of the sensory innervation, also it has this minor portion or the small portion of the motoric function, who tell me that the mandibular nerve is innervating which muscles? Muscles of the masticator. Excellent. So it's the chewing muscle is innervated by the mandibular nerve, the masticatory muscle, which you know that there are 4: temporalis muscle, masseter muscle, and medial and lateral pterygoid muscle, that all innervated by this small portion or the lesser portion of the trigeminal. So a ventrolateral aspect of the pons vareoli here in this region, that in the practical of the central nervous system, you will see all this exit of this cranial nerve, and you have to know it perfectly, is the place of the exiting of the, or passing or exiting of the, or entering to the central nervous system at the anterolateral aspect of the pons. Then is cranial nerve number 6 here. This cranial nerve number 6, it's located in the border between this medulla oblongata and pons vareoli. So the borderline between the ponto-medullary border or the aspect, so is the cranial nerve number 6, is abducens. Then we have the cranial nerve number 7 and cranial nerve number 8, that they are arising from the brainstem, again in the angle between the pons vareoli and cerebellum. This is the cerebellum, and here is the pons vareoli. And there is an angle between them, which is called pontocerebellar angle. So pontocerebellar angle, it's the place for the exiting of the 2 cranial nerve, number 7 facial and number 8 vestibulocochlear nerve, which is, as a matter of fact, again is the border between the medulla oblongata and pons, but because of the angle between the pons and cerebellum, they call it the name of the pontocerebellar angle. Further, we have the cranial nerve number 9, 10, and 11. Those are the 3 nerves that they have. As you know, they are passing through the jugular foramen, and they are arising from the medulla oblongata in the posterior aspect of this structure, which is called olive. This is the structure of the medulla oblongata, which is called pyramid. and here is the place for the passage of the motoric pathway cortico-spinal tract, or that's why they call it pyramidal tract. So here is the pyramid, and here is another structure which is called olive, and behind the olive there is a groove which is called retroolivary groove or sulcus, and the retroolivary groove, it's the place for the exiting or emerging of the three cranial nerve number 9, 10, and 11. Of course, as you know from the first semester, we discussed that the cranial nerve number 11, and we are going also to discuss, it has very important, and it has two parts. The cranial part, which is inside the central nervous system, but it has the spinal part, or sometimes you can find spinal root of the accessory nerve, which is coming from the spinal cord, and usually respectively from segment C1 till C5 and 6 or 6. So they are entering to the skull, the spinal root or spinal part of the accessory nerve, through which opening? The excellent foramen magnum. So foramen magnum, it's the place that the spinal root or spinal part of the accessory nerve it's coming. So then it's joining with the cranial part that we are going to discuss, and they form the accessory nerve that, of course, it's passing together with the 9, 10, 11 to the ventromedial aspect of the foramen, jugular foramen. And finally, the last cranial nerve here from the exiting from the brain stem, and it's the exclusively is the somatomotoric fiber for the innervation of the muscles of the tongue. It's the hypoglossal nerve with one exception, which is palatoglossus, we are going to discuss. It's, as you know, is located or is emerging from the place or groove that is located between the pyramid and olive. This is called, and because it's in front of the olive, it's called pere-olivary groove, or you can say it also the anterolateral groove here, but is most commonly used is pre-olivary groove. It's the place between the pyramid and olive. It's the place of the exit of one cranial nerve, and this is the hypoglossal nerve, cranial nerve number 12. So this is extremely important, the exit of the cranial nerves, the place of the exit of the cranial nerve inside from the brain stem, of course, as I told you, with the exception of the number 1 and 2, that they are not true cranial nerve. The number 1 is a part of telencephalon central nervous system. Number 2, it's the part of the diencephalon of the central nervous system. So that's why we don't consider them as a true cranial nerve, of course, with the cranial nerve number 0. And from 3 till 12, as you see, with this exception of the small part of the spinal part of the accessory, they are arising from the brainstem. So either from the medulla oblongata, either from the pons varelli, or from the midbrain or mesencephalon. An exact place of the exit or emerge of this cranial nerve, definitely you have to know. Then the easier for you that already you studied and you had this exam, that each cranial nerve is passing through which opening of the skull, that very quickly we are going to revise. And as you see, the number of the cranial nerve from the anterior to the posterior is starting. Yes, 1, 2, 3, 4, 5, 6, 7, 8, 9, and the 12, that is the more posterior. And the same here, the same order, also you can see it here, more or less, that the cranial nerve number 1 is passing through the cribriform plate of the ethmoidal bone. Number 2 passing through the optic canal together with one artery which is called ophthalmic artery, thank you. Then we have the superior orbital fissure that most of the cranial nerve they are passing through that. The cranial nerve number 3, oculomotor nerve, cranial nerve number 4, 6, which is the abducens, and the first branch of the trigeminal nerve, which is ophthalmic nerve. Those are the 4 cranial nerves that they are passing through the superior orbital fissure. V2 or maxillary nerve, it passes through the foramen rotundum, thank you, or round foramen, and it enters to the pterygopalatine fossa. It's very important. The mandibular nerve, it passes through the foramen ovale or oval foramen, and it enters to the infratemporal fossa. Then we have number 7 and 8 that we said that it passed through the posterior aspect of the pyramid or the petrosal bone, which is, this opening is called internal acoustic meatus or pore or meatus, is 7 and 8. And then, as we said, the 9, 10, 11, they are exiting they are passing through the jugular foramen. And finally, the hypoglossal canal in the place of the occipital bone in the condyle. So we have the hypoglossal canal that the cranial nerve number 12 is passed. So those are the number of the cranial nerve and the exit of the cranial nerve or emerging of the cranial nerve according to their location and the place through the passing through the opening of the skull, which is the basic information that definitely you have to know it. So now we are going one by one for each cranial nerve, but before we start, as I told you, you have to know that each cranial nerve is composed of what kind of fiber. So it consists of what kind of fiber, or they are carrying what or which kind of the fiber. As you see here, the fibers they are divided to the two category, the motor fiber and the sensory fiber. And the motor fiber, they are subdivided to 3 other category. The somatomotoric fiber. If you don't understand those terminology, then you are lost from the whole peripheral nervous system and central nervous system. So please pay attention to this terminology to understand what is the function of this cranial nerve. Somatomotoric, whenever you hear about the somatomotoric fiber, it means that there are the efferent fiber or motoric fiber that they are supplying the skeletal muscles that they are usually involved with the voluntary motion or movement. So somato, or it has a somite organization of the body, and they are innervating the skeletal muscle. And as you know, here is mentioned that the cranial nerve number 3, 4, and 6. This is the 3, those are the 3 cranial nerves that they are responsible for innervation of the extraocular muscle of the eye. So those are the muscles that they are moving the eyeball. So 3, 4, 6, plus the hypoglossal nerve. These 4 cranial nerves, they are containing the somatomotoric fiber, and they are innervating the skeletal muscle, which are voluntary. Then we have another group of the motoric fiber that is called branchiomotor fiber, or sometimes in English textbook or literature, you can see the special motor fiber. They call it branchiomotor fiber because those efferent fiber or motoric fiber, they are innervating the muscles that they are originated and they are arising from the branchial arch, or better to say pharyngeal arch in the embryological development. So it means, for example, the muscles of the larynx, pharynx, soft palate, and so on. And they are the cranial nerve that they are containing the branchiomotor or special motor function. They are the trigeminous nerve, or the nervus trigeminal or trigeminal nerve, number 5, which is, as right now we said, for example, mainly it's supplying the masticatory muscle. Then we have the facial nerve, which is supplying mainly another group of the muscle of the head, except the masticatory, is mimic muscle, or the muscles of the facial expression. It's the facial. Then we have the glossopharyngeal, vagus, and accessory. The glossopharyngeal together with the vagus, they are making the plexus, which is called pharyngeal plexus, for the innervation of the muscles of the pharynx, respectively vagus for the innervation of the larynx. Accessory nerve is responsible also for the innervation of the muscles of the larynx, and also 2 extra muscle, which is the trapezius and sternocleidomastoid muscle, that we are going to discuss. So those are the branchiomotor. Then we have visceromotor, a common mistake of a student. So as again, whenever you hear visceromotor fiber, we are talking about the autonomic nervous system, mainly respectively for the cranial nerve is parasympathetic fiber. Right now I will tell you not to do the mistake forever that no cranial nerve among these 12 or 13 that you have heard, they don't have, even one, they don't have sympathetic fiber. Yes, sympathetic origin, it's outside of the brain. So that's why they call it thoracolumbar segment of the autonomic nervous system. So be careful, no cranial nerve has sympathetic fiber. So that to be easy, that not to do mistakes. So visceromotor fiber, it means parasympathetic fiber. And parasympathetic fiber is a part of autonomic nervous system. And autonomic nervous system, it means that is innervating that something is not voluntary. It means the secretion of the glands, for example, and also the supplying the smooth muscle that they are not under your control or is not voluntary or involuntary. And the 4 nerves, very famous nerves, that they are, as we mentioned it in the beginning, they are related to these 4 parasympathetic ganglion. They are the oculomotor nerves number 7 and 9 and 10. 10 we said that is the largest parasympathetic nerve of your body. So those are the classification of the motoric. Then the borderline here, it's the sensory, yes. The sensory also, we divide them to the somatosensory, viscerosensory, and special sensory. This is, as a matter of fact, it's the synonymous of the special motor that here we had. The name was branchiomotor. So special sensory. Special sensory, it means is related to the sense organ. Sorry, here is written by Czech language, but Czech, it means the smell, the sense of the smell. Zrak, it means the sense of the vision. Of course, one by one we are going to discuss. Chut, that you see it in the number 7 and number 9 and 10, it's the taste fiber, is the special general sensory fiber, and the vestibulocochlear, which is for the hearing and for the balance and postural position of your body. So those are the special that one by one we are going to discuss. Hopefully we can finish it. So about the sensory, the viscerosensory. The viscerosensory fiber, there are 2 fiber or 2 cranial nerve, which is 9 and 10. They are responsible for the viscerosensory fiber. Sometimes in some literature you will see for this classification or for this group, they call it as a general viscerosensory. Yes, viscerosensory, it means that organs, the sensory innervation of the organs, which is mainly they are responsible for the glossopharyngeal and vagus for the innervation of those. Then we have the somatosensory. Somatosensory, again, they have the somite organization, segmental organization of your body as a dermatome, as a myotome. That is a somite organization. And somatosensory, usually we are mentioning it for the innervation of the skin. Yes, for the skin of the different part of the body. For example, again, trigeminus, or the trigeminal nerve, as we said, that is mainly sensory nerve and a small portion of the motor. Then we have the facial nerve, the small portion of the facial nerve, it has somatosensory. And of course, again, the glossopharyngeal and vagus nerve. So those are also they have. And then finally, we reach to the special sensory fiber. Generally, it is again further, it can be subdivided to the general special sensory and the somatic special sensory. But to be easy here, we classify it as a just special sensory, which is related to the sense organ. It means that smell, it means the vision, it means that the taste, which is innervated on the via the cranial nerve number 7 for anterior 2/3 of the body, of the tongue, and glossopharyngeal for the posterior 1/3 of the tongue or the root of the tongue, and the region of the epiglottis and glossoepiglottic fold, it's by the vagus nerve. And finally, the special sensory fiber is carried by the vestibulocochlear nerve, cranial nerve number 8. For the cochlear part is innervated, is responsible for hearing, and vestibular part is responsible for balance and equilibrium and postural position of your body. So this table, it can help you to recognize, and of course we are going one by one. Hopefully we can catch it up. So here, I have to a little bit talk faster to reach all of them. Here is just to know from the development of this nervous system in the neural tube and neural crest. Usually we have two parts, the basal part and alar part, and those are the fibers that they are coming from the basal part and the posterior part, which is the alar part or the wing part of the neural tube. And those are all the name of the fiber that already in the previous table you had it. And as I said, you see that sometimes they are using as a general and a special, general and a special. And this special is subdivided to the special visceral and a special somatic sensory, which is vestibulocochlear and so on. So cranial nerve number 0, that usually you don't see it in the textbook, but it exists and it's a matter of the discussion, is a rudimentary nerve. Here it is. So it's the mysterious nerve because still the exact function in human being is not defined. Those are location, the cell's body, they are location in the mucosa or the mucous membrane of the nasal septum. So somewhere in the nasal septum, and mainly in a while I will tell you as an accessory olfactory system, you have the Jacobson's organ that it's in the borderline between nasal cavity and the oral cavity, and they are containing the bipolar and unipolar cells. And here, if it is the olfactory bulb and olfactory tract, medial to that they are going parallel with the optic, with the olfactory tract. So be careful, they are not connecting together. So that's why it's separate from the olfactory nerve. And they are going and emerging to the gray matter, which is, as a matter of fact, is this area, which is the anterior perforated substance. Here, this perforating is because of the passage of the vessels. So that's why they call it anterior perforated substance. And also it's interconnected with the different part of the central nervous system, which is the lamina terminalis, septum verum, and hypothalamus. And they are very sensitive to the chemoreceptor, to the chemoreception or the chemoreceptors, and is rudimentary visceromotoric function it has. As I told you, in a human being, it's not that much developed, but as you see, for example, if somebody has cat, so the cats, they are smelling some chemical molecules, or the snake when it's taking some food, so the chemical molecules, it's analyzed by this sense, these nerves and different part of the nervous system, that if this food, for example, is suitable for eating or no. So those are in a snake is a horse, cats, they are much more different, but in human being is a mysterious nerve. So in anatomical textbook, usually they don't talk about this terminal nerve. The first olfactory nerve that again is, as I said, is not a true cranial nerve. So here I wrote some important landmark about each cranial nerve in the beginning that it can be useful for you. As you said, that is not a true cranial nerve, it's a part of the central nervous system, which is telencephalon. And it contains, as we said, again, special sensory fiber related to the sense of smell. So this olfactory nerve is exclusively contain the special sensory fiber responsible for the smell, sense of smell. As we said, that it passed through the cribriform plate of the ethmoidal bone. There are the olfactory pathway is a pathway of the central nervous system, and it's very, very complex and complicated pathway. It's containing approximately 6-7 neurons, and it's also is connected to the part of the central nervous system which is called limbic system, and this limbic system is responsible for the emotional or for the behavior, for the sexual activity, for the memory. Those are the limbic system. And that's why, again, in animal is much more developed that, for example, if they want to find their pairs, so they are starting to smell. So this is the connection with the limbic system, and according to that smell, it's acting sexual behavior or sexual activity. In human being, somehow is existing, but I don't think so that that in the sexual activity somebody is starting to smell something. Yes. So in human being. So this is to consider during the olfactory pathway. You have to pay attention about the two first neuron. The first neuron, there are olfactory cells that they are located in the olfactory region that in a while I will show you, and they are bipolar cells. And these bipolar cells, they are exceptional among the nerve, because it's interesting that these olfactory cells, which are bipolar cells, they are able to regenerate. So this is one of the exception in the nervous system, that the nerve is, thanks to these basal cells that they are around the olfactory cells, they are able to regenerating, and they have also the supporting cells. So for sure you have experience that if you catch a cold and for some times you don't feel the smell, yes, because the virus is attacking, for example, the coronavirus that is very famous, is attacking these olfactory cells and is killing these olfactory cells. But after the normal flu that you have or cold that you have, these sense of smell is usually coming back. And this is thanks to these basal cells that they are regenerating a new olfactory cells or bipolar cells. The second order olfactory neuron is called mitral cells, that they are synapsing with the first neuron. And then finally they go to the primary olfactory center. So here, I have to say that, as I said, that it's usually, we have the accessory olfactory system, or accessory, which is a rudimentary in human being. It's the organ which is called vomeronasal organ or Jacobson's organ. And this vomeronasal organ, it's located in the border between the nasal septum with the oral cavity. And usually they are much more developed in the reptiles, horses, and cats. And they are near to the incisive duct or incisive canal. And they are responsible and they are sensitive to the chemical molecules. So they are chemoreceptors, which is the responsible, and for they are acting, or they are stimulating via the pheromones. Pheromones, they are like hormones, but they are affecting outside of the body. So this is the olfactory region. If you remember the nasal cavity from the first semester, nasal cavity generally is divided to the two regions. The most of the nasal cavity in this area is the respiratory region. Only a small portion of the nasal cavity below the cribriform plate of the ethmoidal bone. Here is the olfactory region. And this olfactory region is differentiated with the respiratory. Bigger region is that the mucous membrane in this area, it somehow is grayish, yellowish, bluish color, and they contain the olfactory cells that they are bipolar cells. If I go through the details here, those are the bipolar cells, and in the dendrite part of the bipolar cells here, they are cilia. Here there are cilia, there are 5-6 cilia that they are located and embedded inside the the mucous membrane of the olfactory region. And when the impulse by the chemical molecules, it's stimulating the cilia, the impulse is going through the dendrite to the cell body of the olfactory cells, which are bipolar, and then the axons, they are passing through this opening of the cribriform plate of the ethmoidal bone, and they enter to the telencephalon, and they enter to the olfactory bulb. Inside the olfactory bulb, there is a second order neurons, which is called mitral cells. So those are the mitral cells that they are synapsing with the bipolar cells, and they make the olfactory glomerulus. And the fiber from the olfactory bulb is continue dorsally as an olfactory tract that you can see it here. The olfactory bulb, which is containing the mitral cell and olfactory glomerulus at the synapse position, is continue dorsally as an olfactory tract, and it reached to this area, which is called olfactory trigone. Now the nervous system central is starting, and you see how it's complex, yes? But it's important and it's interesting. So here, the first neuron that is stimulated is the anterior olfactory nucleus, which is, as a matter of fact, is a part of the olfactory tract. This is the first one. And then when it reached to the olfactory trigone, here the olfactory tract is divided to the lateral and medial stria. So lateral and medial stria, this is the lateral and this is the medial stria. In some textbook you can also find the intermediate stria. And then through this stria, they are going to the different part of the central nervous system, which is anterior perforated substance, uncus gyri hippocampi, hippocampal gyrus, amygdaloid body, and septum verum. Those are the old part of the cortex in the central nervous system, which are in the different part of the brain that they are feeling that this smell that it came to your nasal cavity, for example, is going, these chemicals in the air, it's going to this area or olfactory area, is stimulating this cilia inside this mucous membrane, because these chemicals, they are dissolved inside the mucous membrane, is stimulating this cilia, the impulse is producing. Because these cilia, they are sensitive to the chemical molecules. And then it goes to the olfactory cells, bipolar cells, the axon is synapsing to the second mitral cells, and then it goes to the olfactory tract, to the olfactory trigone, the lateral and medial stria and intermediate stria, and then it goes to the, this is only a part of the place that the impulse goes, and here, this area, it's percepting and feeling that this smell that you smell is the smell of the dissection room, or is the perfume of the Christian Dior, for example, yes? So this is the function in this area, that there are the primary olfactory cortex, or the olfactory brain or cortex, that they are sensitive and they are analyzing these molecules in the body. So this is, they have the direct olfactory pathway and indirect olfactory pathway, which is going to the limbic system. This is just a schema to understand. This is extremely difficult and complex system. That is an olfactory bulb, tract, and trigone to the lateral and medial stria. The medial stria is going to the above the corpus callosum as a longitudinal, medial and lateral longitudinal stria, which is forming the indicium grisum, is all over the corpus callosum above. It's going and is continue to the gyrus fasciolaris, continue to the gyrus dentatus. It continue to the hippocampus, the area number 27, 28, 34 usually, and the hippocampal gyrus, and the uncus of the hippocampal gyrus, and amygdaloid body. So here, those are the area that they are the perception of the smell, it happened, but as we said, is connected to the limbic system, which is responsible for the, for example, the sexual behavior, emotion, memory, and smell. So, and the part of this limbic system is, as you see, when it reaches to the hippocampus, is continue as a fornix, is continue to the mammillary body. Mammillary body is a part of hypothalamus, which is interconnected to the anterior nucleus of the thalamus. And anterior nucleus of the thalamus is interconnected to the cortex of the above the corpus callosum, which is called cingulate gyrus here, and then again is going back to the hypothalamus, is making a circuit, or which is called Puppet's circuit, that you will see it in the chapter of the limbic system and olfactory system. So there are different other parts that, like a habenular reticular formation, the hypothalamus, the nucleus of the thalamus, that there are this impulse of the olfaction, it goes to the different part of the body. So this cranial nerve number 1, 2, and 8, they are a part of the central nervous system. Hopefully you will have again the pathway of this sensory pathway that they have, but I am trying to cover this small part. Optic nerve, again, is not a true cranial nerve, it's a part of the, this time, diencephalon. It contains, again, pure, exclusively special sensory fiber related to the vision. It's passing through the optic canal, as you know, together with the ophthalmic artery. The optic pathway, be careful, you need it for anatomy, you need it for physiology, you need it for pathology, internal medicine, ophthalmology, till your state exam. It has four neurons. 3 of them is inside the retina that I'm going to discuss. And the first one is inside the brain, which is the lateral geniculate body. So the optic fiber, which is optic nerve, as a matter of fact, is axons of the third neuron in the retina, which is called ganglionic cell or ganglionar cells. They are crossing each other, not all of the fiber, but the place of the crossing of the optic nerve is called optic chiasma, and the temporal or the lateral part of the retina is not crossing. The nasal or medial part is crossing, and after the optic chiasma, we have whatever posterior to the optic chiasma is called optic tract, and this optic tract it goes in 80% to the fourth neuron, which is called lateral geniculate body or lateral geniculate nucleus. So, which is a part of the metathalamus, and it's some part it going to the pretectal nuclei for the reflex, for the papillary light reflex. If somebody put a light in your pupil, so your pupil is becoming contracted and is becoming narrow. So this is the papillary light reflex that in the normal examination they can use it. It can go to the superior colliculus for the gaze reflex. It means the coordinated motion of the eyes. It's going to the suprachiasmatic nucleus of the hypothalamus for the circadian rhythmus. So it means that if you go to the other part of the world and your sleep-wake cycle it's disturbed, is to this because of this suprachiasmatic nucleus of the thalamus. And finally, from the lateral geniculate body, the pathway is going to the place that it's a perception of the vision, the light that is coming to your eyes, and its primary is in the occipital lobe, is area number 17 according to Brodmann area, and secondary vision, which is giving you the more detail, for example, the color, the 3D object that you saw is in the occipital lobe as well, and is area number 18, 19. This number is according to the scientists, which is Brodmann, and some of them, they are very important to know. The connection of the lateral geniculate nucleus with the visual cortex, it's the optic radiation. So here you have the things that we say. Be careful, optic nerve, we said again, is not a true cranial nerve, is a part of the diencephalon. And 4 neurons, we have 3 of them is in the retina. In the next slide I will tell you what is important, that since it's a part of the central nervous system, which is diencephalon, also it contains its meninges. So it means that it has 2 covering, the external vagina, which is covered by the dura mater, which is formed by the dura mater, and the internal vagina, which is formed by the arachnoid and pia mater, the other 2 kind of the meninges. So the optic nerve is containing all these layers of the meninges because of the part of the central nervous system. So that's why if somebody has a tumor of the optic nerve, as a matter of fact, is a tumor of the central nervous system. So the kind of the tumor that is arising in the optic nerve is a type of the tumor that is arising in the brain, for example, because it's a part of the central nervous system. So then it's coming from the apex of the orbit out, it's going to the optic canal. Chiasma opticum is the place that is crossing, and behind the chiasma, it's the optic tract, which is lead 80% to the lateral geniculate body, which is the neuron number 4, and then it's going as an optic radiation or the geniculocortical tract to the visual cortex, area number 17 in occipital lobe. So just to simplify it again, so we will reach to the normal cranial nerve, which is a little bit more easy. Yes, I know that is too much information. So if you see something, so the light of this object is going to the cornea, it passing through the transparent part of the eye. It means that it's going to the aqueous humor, vitreous humor, passing through the lens, which is crossed in the lens region, and it reaches to the retina. Inside the retina, you have the two layers, pigmented layer and the layer that it contains the photoreceptors. In nasal cavity and olfactory region, you had the receptors that they are sensitive to the molecules, chemical molecules. Here, the photoreceptors that they are rods and cones, they are sensitive to the light. Immediately when the light is happen, it's going into the retina, so they are stimulating. The impulse is starting and it's going to the second neuron, which is called bipolar cells, is located in the retinal ganglion. Then the axon of the bipolar cells is synapsing with the third neuron, be careful, third neuron, which is called ganglion cell, which is located in the optic ganglion. And the axon of this optic nerve, or of the ganglionic cells, they are converging together and they make the optic nerve. So if somebody asks you, optic nerve is, as a matter of fact, is an axon of which neuron? Is a matter of fact, is the axon of the neuron number 3, which is ganglion cells. Yes? Here, now, the optic nerve is formed. Then, when it forms, it's passed, it has 4 pathways. It passed as an intraocular part, then it's going to the orbital part. The orbital part, it means that in the retrobulbar space, it's passing. Then it's going to the optic canal together with the ophthalmic artery, and then it coming to the intracranial space of the skull. So those are the 4 parts of the optic nerve, the pathway, and the sheets of the optic nerve, as we say, that is composed of the meninges that you have it. It has a topographical relation of the optic nerve with the ciliary ganglion, which is a parasympathetic ganglion, but parasympathetic is carrying by the oculomotor nerve, be careful. It's just, it has a relation to that, which is approximately is located lateral to the optic nerve, near to the optic, or 2 centimeters behind the eye bulb. Then it has a close relation with the ophthalmic artery inside the optic canal. You say that it has an ophthalmic artery, and this ophthalmic artery, it gives very important artery which is called centralis retinae. I talked about this before also. This centralis retinae is very, very small artery, approximately 1 centimeter behind the eye bulb. It enters to the optic nerve, and it passing inside the nerve, and it's end artery. It means it doesn't have any anastomosis. So this small narrow artery, if with any reason occluded, like a thrombosis or like any reason, so the consequence, it means that it's blindness. Yes? The other artery that they have anastomosis together and they have collaterals, if one artery is occluded, the other they can supply it. So the tissue will not die. But central retinal artery is the end artery that if it's occluded, its retina is damaged. And in this case, it caused the blindness. Very small artery, important. And also, it has relation with the infundibulum of the hypophyse that in the central nervous system. Here is a very nice picture to pay your attention. For example, in dissection exam, if I put the needle here, this is optic nerve anteriorly. If I put the needle here, is the place that is cross, is optic chiasma. If I put it behind, it means that is optic tract. Yes? Be careful, 3 structure, optic nerve is the axons of the third neuron, optic chiasma, which is not all the fiber, but some of the fiber is crossing. The temporary region is not crossed. And then behind is the optic tract, which is end up to the lateral geniculate body in 80%. Of course, it's going to the superior colliculus, pretectal area, or the suprachiasmatic nucleus of the hypothalamus. And here, the last one is the last picture. This is the schema of the pathway of the optic nerve. The fourth neuron, the optic nerve is coming outside from the scleral cribriform plate. There are the small foramens in the sclera that is coming out from the region which is called optic disc here. The optic nerve is passing here, it's going to the optic chiasma, and here is going as an optic tract, and is going to the lateral geniculate body, and from the lateral geniculate body, this tract is called optic radiation, or the geniculocortical pathway or tract, which is going to the primary visual cortex, which is area number 17, and secondary 18, 19. And finally, we are starting the true cranial nerves, which is the first one is the oculomotor nerve, very important. Exit, we said it's coming from the fossa, which is located between the cross or the peduncles of the cerebrum. Is the cerebral peduncle. That's why they call it interpeduncular fossa, is a part of midbrain. Oculomotor nerve, now we are starting to have a mixed nerve. Oculomotor nerve is a mixed nerve. So it's not exclusively, for example, somatomotor, not exclusively somatosensory, it's a mixed nerve. What kind of fiber it has? It contains the somatomotoric fiber. And as I said, whenever you say about the fiber, immediately you have to say the nucleus that is located there in the central nervous system. The nucleus for the somatomotoric fiber of the oculomotor nerve is easy. It's called motor nucleus of oculomotor nerve, or sometimes they call it nucleus originis. It's responsible for the extraocular muscles, except two muscles, very important. The superior oblique muscle is not innervated by oculomotor nerve. Superior oblique is innervated by cranial nerve number 4. And the lateral rectus muscle is innervated by cranial nerve number 6. Yes? So remember 3, 4, 6, they are the nerves that they are innervating the extraocular muscles of the eye for the movement of the eyeball. Most of them, they are innervated by oculomotor nerve, except these two, superior oblique by cranial nerve number 4. Remember SO4. SO4 is what? What? Sulfite. So it's chemistry if you know. So SO, superior oblique 4, trochlear nerve. Yes? So, and lateral rectus. So the other part of the oculomotor nerve is visceromotor fiber. We said visceromotor, it means parasympathetic fiber. And the nucleus of this visceromotor is accessory oculomotor nerve, or very famous nucleus, they use it, is Edinger-Westphal nucleus. Edinger-Westphal nucleus is the parasympathetic nucleus of the oculomotor nerve for the innervation of intraocular muscle. It means two muscle is innervated by this nucleus or the visceromotor. Ciliary muscle is a smooth muscle which is responsible for the accommodation of the lens for the near vision, and a sphincter muscle of the pupil which is making the constriction of the pupil, which is called meiosis. Very, very important information. Oculomotor nerve also has another nucleus which is called Perlia's nucleus or medianus nucleus, is unpaired, is not double nucleus, and is associated with the ocular convergence. As you know, it passed through the lateral wall of the cavernous sinus, it passed through the supraorbital fissure, and oculomotor nerve, it gives now the nerves are starting to give branches. It has two branches. The superior branch that it pure exclusively, again, each branch you have to know it contains what kind of fiber. Superior branch of oculomotor nerve, it's composed of somatomotoric fiber. for the levator palpebrae superioris muscle and superior rectus muscle. Inferior branch of the oculomotor nerve, not only it contains somatomotoric fiber for the other muscles, except these two, but also, be careful, it has parasympathetic fiber for the root of the ciliary ganglion, responsible for innervation of ciliary muscle and sphincter muscle of the pupil. Extremely, extremely important. So here is the recapitulation what we said. Those are the list of the muscle that is innervated by the oculomotor nerve. It means that 4 muscles extraocular together with 1 muscle of the eyelid, which is the levator palpebrae superioris. Here it must be repeated. The superioris. The nerve, the nucleus is called the nucleus of the oculomotor nerve, or nucleus originus, or motor nucleus of the oculomotor. As we said, superior oblique 4, lateral rectus number 6, nucleus medianus for the convergence of the eye. Visceromotoric function, be careful, parasympathetic function is related to the ciliary ganglion. It means that this inferior branch of the oculomotor nerve is making a parasympathetic route for the ciliary ganglion, which is then via the short ciliary nerve. In a while I will tell you, is innervating these 2 muscles, the sphincter muscle of pupil and ciliary muscle. This is causing narrowing of the pupil, which is called miosis, and the ciliary muscle accommodation for the focus on the near object. Here is the same information that I already said, that oculomotor passing, and here is the schema how the branches of the oculomotor is innervating different structures. So this is superior branch, be careful, which is supplying 2 muscles. One muscle of the eyelid, levator palpebrae superioris, and the other is superior rectus. This is inferior branch that is supplying the other 3 muscles, medial rectus, inferior oblique, and it has parasympathetic fiber, which is going to the ciliary ganglion via the inferior branch of the oculomotor nerve. Inside the ciliary ganglion, that is said that it's in the retrobulbar space. Here, the preganglionic parasympathetic fiber synapsing inside, and then the postganglionic fiber via the short ciliary nerve, or ciliaris brevis, is innervating the 2 muscles, which is the ciliary muscle and sphincter muscle of the pupil. And here is very nice of the passage of the oculomotor nerve, which is the passing through the lateral wall of the cavernous sinus. It enters to the common tendinous ring, or the annulus tendinus communis, or the tendinal, the ring of the Zini, is innervating the muscles, and inferior branch is connected with the ciliary muscle, and here those are the short ciliary nerve, which is innervating the ciliary muscle and sphincter muscle of the pupil here. And here is very nice picture that is show that how the oculomotor nerve is coming from the superior orbital fissure and is going to this annulus tendinus communis, and it's divided to the superior branch, inferior branch, and here is ciliary ganglion as a parasympathetic route for the ciliary ganglion. More details about the ciliary ganglion. Remember forever that whenever you hear parasympathetic ganglion, it means ciliary, otic, pterygopalatine, submandibular. Always you have to discuss about the 3 fibers, not only parasympathetic, but 3 fibers. One root is a parasympathetic root, or visceromotoric root, which is here in this case is the inferior branch of the oculomotor nerve, is going to the parasympathetic, and only, be careful, only parasympathetic fiber is synapsing inside the ganglion. Then the postganglionic fiber is going through the short ciliary nerve, and is innervating that two muscles, smooth muscle, ciliary muscle, and the sphincter muscle of the pupil. Here, as you see, we have sympathetic root. Sympathetic root is arising from the other place. It means that it's arising from the superior cervical ganglion. And the nucleus, the paraganglionic fiber of the sympathetic fiber, is arising from the center, which is called ciliospinal center, which is, as a matter of fact, is in the segment of the C8 till T2 of the spinal cord. It's making a sympathetic root, and via the wall of the arteries, mainly ophthalmic arteries, it's going to the ciliary ganglion, but as you see, it doesn't synapse. It's just pass, and it's going to do the short ciliary nerve, and sympathetic fiber is innervating another kind of muscles, which is called dilator muscle of the pupil. Parasympathetic is making constrictor muscle of the pupil, or sphincter muscle of the pupil, which is making narrowing of the pupil. It means meiosis. Sympathetic, which is related to fear and fight and flight. When you are afraid, what will happen? Your pupil is becoming dilated. So this is called mydriasis. For example, next week, if you see the topographical test, so immediately your pupil will become mydriasis. Yes, please. In the ciliary ganglion. That's why they call it this four ganglion that I mentioned, otic, remember, otic, submandibular, pterygopalatine, and ciliary ganglion, those two four. Just the parasympathetic fiber, which is dividing to the paraganglionic before inter. Then it enter to the ganglion, synapsing with the postganglionic fiber, which is the effector, and then it goes to the effector organ, yes? Sympathetic root is just passed through. And another root, which is here, is the sensory root. Each ganglion also has sensory root. Sensory root for the ciliary ganglion is via ophthalmic nerve, is a branch of trigeminal nerve. Just to be easy for you, always sensory root for all these four parasympathetic ganglion is one of the branch of trigeminal nerve. Yes. So here in this case is ophthalmic, mainly the nasociliary nerve is making a root. As you see, it doesn't synapse. It's just passed through, and is supplying the sensitive innervation of the bulb, eye bulb. So those are the ciliary ganglion. Be careful again, very, very important how this responsible for the parasympathetic root is inferior ramus or inferior branch of oculomotor. Nucleus is Edingel-Westphal or the accessory oculomotor nerve. Why you learn it? That if something happened in the central nervous system, something happened to the oculomotor nerve, something happened that you don't see it inside the brain, the patient will come as a complaint that something happened to me, yes? And you see the patient will come with the mydriasis. Why? Because oculomotor nerve, parasympathetic part, it doesn't work, yes? So it cannot do the constriction muscle of the pupil, so the mydriasis is happening like this. Or we said that nucleus medianus or Perles nucleus, it's responsible for the convergence of the eye. So convergence of the eye, it means that the movement and focusing eye to the point as a convergence. And you see that if there is a damage, it will be a strabismus. The strabismus is the divergence of strabismus. It's the consequence of the damage of the oculomotor nerve. And this damage, either via for example, the tumor in the sella turcica of the hypophyseal intracellular tumor, or is compression by some vessels, mainly internal carotid artery. So the doctor will send him to the CT or MRI, and he will see that the growing tumor is pressing the oculomotor nerve. So treatment. Yes? So that's why you learn this thing. It's not just name for you, it's all of them, they have their own clinical significance. The trochlear nerve. Easy. Trochlear nerve is the cranial nerve number 4, is leaving from the midbrain. It's the place that is emerging is inferior, below the inferior colliculus. As we said, there are some exceptions for that. Thinnest cranial nerve is the only cranial nerve that is leaving the brainstem in the dorsal aspect. It's exclusively, it contains somatomotoric fiber. For what? For innervation of superior oblique muscle. Yes? So very important is that the trochlear nerve, before it's coming out from the midbrain, is crossing. It's crossing, and it's called the decussation of the trochlear nerve. And it's passing through the margin of the tentorium cerebelli. Tentorium, it's dividing the cerebellum and the cerebrum, and at the margin of that one is the tentorium, trochlear nerve it passed, so it can be compressed by the enlargement of the tumors in this area or any pathologically structure. It passed through the lateral wall of the cavernous sinus, and it's going below the cranial nerve number 3, above the V1, and it passing through the supraorbital fissure. So function, as we said, is innervation of the obliquus superior, or superior oblique muscle. What is the function of the superior oblique muscle? You have to know the function of the superior oblique muscle, that if trochlear nerve is damaged and it cannot supply this muscle, your clinical manifestation, the patient will come complain what? Superior oblique, be careful not to do the mistake, in opposite to the rectus muscle. Rectus superior is making up, inferior down, lateral abduction, medial adduction, yes? But oblique muscle, superior oblique is making depression of the eyeball. It's making depression and is making abduction and it's making the intrusion, some internal rotation of the eye. So that's why those people that they have damage of the trochlear nerve, they cannot come down from the stairs, because they cannot look at the downward. Yes, they fall down from the stair because they cannot watch the stair. This depression function, it will be damaged. And the nucleus is the motor nucleus or originis nucleus in the trochlear nerve, and the rest we said it. Here, as you see, again, here is the inferior colliculus, here is superior colliculus, is a part of the tectum mesencephaly or the quadrigeminate plate. Here is the dorsal aspect of the brainstem, the trochlear nerve passing, lateral wall of the cavernous sinus, doesn't enter to the annulus tendinous ring or the common tendinous ring or the ring of the Zini. It's going above that and is supplying the superior oblique. Superior oblique, you will recognize it, that is turning, the tendon is turning around this structure which is called trochla. And here is a very nice thin nerve which is innervating this superior oblique muscle. I jumped the cranial nerve number 5 because we finished this nerve that they are responsible for the innervation of the extraocular muscle, which is 3, 4, 6, and then I will return back to the trigeminal nerve, don't worry. So 1 hour, oh my God. Okay, abducens nerve, again, is pure, exclusively somatomotoric nerve. Those are the easy nerve. Wait, when we go to the glossopharyngeal vagus, it has all fiber, all. So you have to know the nucleus, you have to know the fiber, you have to know the function, you have to know the branches, and the nightmare is starting. So now enjoy still. So the abducens is the exclusive somatomotoric fiber. The nucleus is called motor nucleus of abducens nerve. It doesn't have a specific name. It comes the names. And or originis, and supplying the lateral rectus. Lateral rectus, what does it do? Abduction of the eyeball, yes? If there is a damage, so the patient cannot do the abduction. So what will happen? Diplopia, double vision during to this movement. And of course, the strabismus, the convergence strabismus. It passing through the cavernous sinus, not lateral wall, but it passing through the cavernous sinus, and it passing through the superior orbital fissure and passing through the common tendinous ring. So the somatomotor, we said, rectus will be lateralis, we said, the lesion is convergence strabismus, this is C, and diplopia that we said it. And here is just the revision. In the first semester, you saw the structure that they pass through the cavernous sinus. The cranial nerve number 3, 4, V1, V2 in the lateral wall. Inside, it's the abducens, this is, which is lateral to the, which vessel it passed through the cavernous sinus? Which artery it passed through the cavernous sinus, please? Yes, internal carotid artery, the cavernous part of the internal carotid. So be careful about this picture, the 6 structure, they are passing through the cavernous sinus, 4 of them in the lateral wall, 2 of them, including the abducens, is in the center or through the cavernous sinus structure. And here also is the schema of the superior orbital fissure and inferior orbital fissure, the structure that they pass. We already, we said it in the skull, the topographical relation of the structure that they pass through the superior orbital fissure, inferior orbital fissure, and optic canal, that it's important. And now trigeminal nerve. Oh my God. Itself, it has 3 nerves, and we have 1 over, and 30 seconds. Trigeminal nerve. It's coming from the anterolateral part of the pons. It's contained the greater portion, which is sensory root, or sensory portion, is originated from the pseudo-unipolar cells of the trigeminal ganglion or semilunar ganglion or Gusser's ganglion, 3 names for the trigeminal ganglion. And the axon of this sensory fiber, it goes to 3 sensitive nucleus of the trigeminal nerve. Very important. Pontine or principal nucleus is responsible for epicritic sensibility. Spinal nucleus is responsible for the protopathic sensibility. It means pain and temperature. And the mesencephalic nucleus is responsible for the proprioceptive impulse. This mesencephalic nucleus has the mesencephalic tract that it consists pseudo-unipolar neurons, and these neurons, they are not inside the trigeminal ganglion. It doesn't synapse there. They are passing through without interruption, without synapsing. The sensory ganglion for this nucleus is located inside the brain exceptionally. Why is important? You have somebody trigeminal is responsible as a nerve for the most innervation of the sensory innervation of the face region, for example, or some part of the head region, yes. If somebody touch, for example, different part of your face, the impulse from the nerve, the dendrites, is going to the trigeminal ganglion, to the pseudounipolar cells, and then the axon from these cells is going to which nucleus? Is touch, pontine nucleus, principal nucleus. Epicritic, it means that touch, vibration, small pressure, this is epicritic. If you have toothache, it has a severe pain suddenly in upper jaw, for example, or lower jaw, via the mandibular or maxillary nerve, it's going the dendrite to the trigeminal nerve, pseudounipolar cells, and then the perception, it goes to the axon, it goes to the spinal nucleus because it's for the pain or temperature. What is proprioceptive impulse? Do you know? Anybody? Proprioceptive? Proprioceptive impulse is anything relation to the movement. It's a sensory, yes? Be careful, it's a sensory. But is related to the movement. How? It's sensory receptors inside the muscles, inside the joints, inside the capsules, inside the ligaments, inside the tendons, that they are sensitive and regulating how the contraction will happen, how the tendon will be shortening and lengthening, yes? So those are the proprioceptive impulse. For example, you have chewing gum in your teeth, in your mouth, and you know how much you have to do pressure because you have the periodontal ligament, yes? These receptors, they are giving you to the temporomandibular joint, for example, how much you have to need to press this chewing gum. But if you put sukhari, very hard bread, in your mouth, you need more pressure to break down this thing. So those are the impulse that is coming from the proprioceptive impulse to the mesencephalic nucleus. Of course, trigeminal nerve has lesser portion, only mandibular nerve. It has also lesser portion, which is the somatomotoric fiber, responsible for the masticatory muscle, mylohyoid muscle, anterior belly of digastric muscle, and via the otic ganglion is much more complicated. It's innervating the tensor veli palatini and tensor tympani muscle in the middle ear, but the origin is other nerve that we are going to discuss. So it's the biggest cranial nerve, as we said, here is already we said. Those are the area of the innervation of the trigeminal nerve. That this is the front, this is the first branch, this is the second branch, the area, and this is the third branch. So here, as you see, is subdivision of the first branch, subdivision of the second branch, subdivision of the, or area of the sensory innervation of the third branch. Here, be careful. This is the line which is connecting one auricle to the other part of the auricle, this line. Whatever is in front is territory of the trigeminal nerve. Whatever is backside to this interauricular line, it's the innervation via for the cervical plexus or the dorsal nerve from the spinal nerve, dorsal branch of the spinal nerve that we are going to, is in the spinal cord chapter. This is the things that we said. Those are the masticatory muscle and other muscles that they are innervated by the mandibular part or minor portion of the trigeminal. The facial and glossopharyngeal are responsible for the innervation of the tensor veli palatini and tensor tympani, but via a branch of the mandibular nerve, mainly the medial pterygoid nerve, through the otic ganglion. Those are the nucleus that already we discussed it, and those are the branches of the trigeminal that where does it pass? We said V1 superorbital fissure, V2 foramen rotundum, and V3 oval foramen. And the trigeminal ganglion, it contains, or gasseri, or semilunar, it contains pseudo-unipolar cells. The dendrites, they are the peripheral branch of the trigeminal, all three branch, and axons, they are going to the different nuclei that we say pontine, spinal, and mesencephalon. Axon of motor neuron nucleus is going as a masticatory nucleus. The name of the motor nucleus of the trigeminal is the masticatory nucleus or motor nucleus, and is responsible for innervation of masticatory muscle and the other muscles that we already mentioned. So very quickly, the branches of the trigeminal. So it's the most medial branch. It's pure somatosensory. It's passing through the lateral wall of the cavernous sinus. It's going through the superorbital fissure. It's giving the tentorial branch, frontal branch, lacrimal branch, and nasociliary branch that in the region of the head and neck, we already discussed these nerves. Here is the frontal branch. All of them, they are passing through the superorbital fissure. This is the lacrimal nerve, which has the interconnection with the maxillary branch of the zygomatic branch of the maxillary nerve. And here is the nasociliary nerve. And as you see here, is making a sensory route for the ciliary ganglion, the nasociliary nerve. So the sensory route for the ciliary ganglion. So those are the area that is sensitively innervated by the V1 or the ophthalmic nerve in the orbital region, conjunctiva, skin, and the mucosa. This is the place for the passage of the frontal nerve. Here is the place for the passage. Here is the area of the frontal nerve innervation. So here is the different, we said it in the head and neck region. The lacrimal nerve, which is innervating the lacrimal gland. Be careful, be careful. Lacrimal nerve itself, because it's arising from trigeminal nerve and branch ophthalmic nerve, and ophthalmic nerve is exclusively a somatosensory nerve, so cannot do the secretion of the lacrimal gland because it doesn't have parasympathetic. But lacrimal nerve, it's taking the parasympathetic fiber from the pterygopalatine ganglion. The parasympathetic route for the pterygopalatine ganglion is the facial nerve, respectively the greater petrosal nerve, which is carried by the zygomatic nerve, branch of the trigeminal nerve, which has communicating with the lacrimal nerve. So much complicated, but it's very nice. So here is the communication, the zygomatic nerve, which is giving the parasympathetic to the ganglion, to the lacrimal nerve, and then lacrimal nerve also it can do the secretomotor innervation or parasympathetic innervation of the lacrimal gland, that the production of the tears is happen, especially in the examination period. So the third nerve, nasociliary nerve, which giving the posterior ethmoidal, anterior ethmoidal, the end branch, it's the infratrochlear nerve. It gives the long ciliary nerve. It gives the sensory route for the ciliary ganglion, and here is the short ciliary nerve. Those are the retrobulbar. Maxillary nerve is the same as ophthalmic nerve, exclusively pure somatosensory fiber. It passing again through the lateral wall. It going to the foramen rotundum, we said, pterygopalatine fossa, giving meningeal branch. The same, it goes parallel with the middle meningeal artery to supplying the meninges intracranially. Gives very important nerve, infraorbital nerve. We said it in the head and neck region in the first semester. It's the place for applying of the anesthesia for dentistry. Infraorbital nerve block. It giving the superior alveolar nerve, which is divided to the posterior, middle, and anterior for innervation of the molar region, premolar, and the frontal segment of the tooth. They are making a superior dental plexus, which is innervating the dental pulp and the gingiva and periodontium. It gives zygomatic nerve, which is going to the zygomatico-orbital foramen, then is subdivided to the two branches, zygomatico-temporal and zygomatico-facial, for innervation of the malar region or the cheek region, and innervation of the temporal region. That it's important. Here is a very nice picture of the of dissection of the trigeminal nerve and the trigeminal ganglion, which is divided into the ophthalmic. Here is the maxillary nerve, which is passing through the foramen rotundum and continue as an infraorbital nerve, is going through the infraorbital fissure, it's going to the infraorbital sulcus, it's going to the infraorbital groove, and here is coming out of the infraorbital foramen. Here, at the place that it's coming out of the foramen, it immediately gives four branches, which is called pes anserinus, for innervation of the lower eyelid, for innervation of the upper lip, for innervation of the vestibulum of the nasal cavity, and for innervation of the nasal wing, skin of the nasal wing. Those are the pes anserinus branch of the infraorbital nerve after exiting from the foramen here, which is very important for the traumatology. If you has somebody breaking in this area, the first examination is you have to touch this area, lower lip, upper lip, lower lid, upper lip, nasal wing. If there is a damage or lose of this sensation, it means infraorbital nerve is damaged. Yes, those are the posterior superior alveolar nerve for which is passing through the maxillary tuberosity. Here you do the injection, of course, for the anesthesia. For innervation of the usually third molar and second molar. First molar is plus minus. It can be with the posterior, it can be with the middle. So the first molar and the premolar is by middle, and the canine and incisor by the anterior superior alveolar nerve, branch of the infraorbital nerve. Those are the branches. Then we have the ganglionar branches. Here is the pterygopalatine ganglion, which is, it has related to the all branch of the maxillary nerve, especially pterygopalatine nerve or ganglionar nerve. And there are 7. We already discussed it in the first semester. Those are the for the innervation of the hard palate, for innervation of soft palate, for the isthmus falcium, palatine tonsil, posterior aspect of the nasal cavity. Those are all the branches that they are responsible for the supplying the glands of this area for the parasympathetic through the pterygopalatine ganglion. And here is very nice connection of the lacrimal nerve with the zygomatic nerve, which is the communicating branch of the zygomatic nerve carrying the parasympathetic from the pterygopalatine ganglion to the lacrimal nerve and then secreting the lacrimal. And those are the zygomatico-facial and zygomatico-temporal branch of the zygomatic nerve. Yes, zygomatic we already said, the palatine nerve we said it. Those are the branches that already we said it. And mandibular nerve. Mandibular nerve, it has one exception, and the exception is that is not pure sensory, but it's a mixed nerve. So it has mainly somatosensory fiber, but it has the small portion or minor portion of the somatomotoric fiber. It means it passed through the oval foramen to the infratemporal fossa, and it giving the meningeal branch. If you remember, it passed through the foramen spinosum together with the medial meningeal artery for the supplying of the meninges. It's the sensitive. Motor portion is supplying masticatory muscle together with all this muscle, together with the tensor tympani and tensor veli palatini and anterior belly of digastric and the mylohyoid nerve muscle. Auriculotemporal nerve, very important nerve, responsible for innervation of the sensory innervation, for the external acoustic meatus, tympanic membrane, skin of the temporal and anterior auricular and upper part of the parotidomasseteric region, and also sensitive innervation of the TMJ, temporomandibular joint. As I told you before, whenever you see that auricular temporal nerve is coming as a one branch and then is separated and then again is joining, so they make a loop or window, and through this window it passes the middle meningeal artery. So in any picture, if you see that there is a nerve that is making a window and again it's separating and again they're connecting, and through this window it passes an artery, this artery is middle meningeal artery, and the nerve is auriculotemporal nerve. What is another importance of this nerve is auriculotemporal nerve is carrying the postganglionic parasympathetic fiber from otic ganglion to the parotid gland and is making a secretion of the parotid gland, but is taking it from the otic ganglion, which is the parasympathetic route for the otic ganglion is cranial nerve number 9, glossopharyngeal nerve, through the inferior salivatory nucleus that hopefully we can catch it up. So those are the structure that we said about the ganglion oticum and the inferior salivatory nucleus for innervation of the parotid gland. And those are the branches of the mandibular nerve: meninges, buccal branch, auriculotemporal, lingual nerve, and inferior alveolar nerve. Very important. Inferior alveolar nerve is going to the mandibular canal, to the mandibular foramen. It's going inside the mandibular canal. It gives the inferior dental plexus as a gingival branch and dental branch, and is coming out under the premolar region, the usually second premolar, as a mental nerve, and then it continue out as a pressure point for the examination of the trigeminal. So be careful, the palpatory examination of the trigeminal nerve is this points that the branches is coming out. Mental nerve, mental foramen, you can press it if the patient has a problem, so he has a pain. Then for the mandibular nerve, here is for the maxillary nerve, infraorbital foramen, and here is the supraorbital foramen for the ophthalmic nerve. So almost they are in one line, the pressure point or palpatory examination of the third branch, second branch, and first branch of the trigeminal nerve. Buccal nerve is pure sensory, one of the most important mistake of the student. Be careful, buccal nerve, branch of the mandibular nerve, it does not innervate buccinator muscle. Yes? Buccinator muscle is considered as a mimic muscle and is innervated by the buccal branch of facial nerve. Don't do this mistake. Lingual nerve is the pure sensory, is innervating the anterior two-thirds of the tongue and sublingual, submandibular region, receiving the parasympathetic fiber from the chorda tympani, branch of the facial nerve, for the submandibular ganglion. Very important. The route for the submandibular ganglion is facial nerve, but this time is chorda tympani. For pterygopalatine it was the greater petrosal nerve, and is responsible for the secretion of the sublingual, submandibular, and the small salivary gland in the floor of the mouth and anterior two-thirds of the tongue. Inferior alveolar nerve, we already said that it's is a mixed nerve. So it means it's somatosensory and somatomotor nerve. Somatosensory for the lower jaw, teeth of the lower jaw, and somatomotor for innervation of the anterior belly of digastric and mylohyoid. So it means that some branches is exclusively sensitive, some branches is the motor. Again, you see the lingual nerve, be careful, is 1 centimeter in front of the inferior alveolar nerve, passing to recognize inferior alveolar nerve. It's going to the canal. Here you see that it's giving before it enters to the foramen mylohyoid nerve for the mylohyoid muscle and anterior belly of digastric. And lingual nerve is going in front of that in the pterygomandibular space between the lateral medial pterygoid muscle and the ramus of the mandible. So here is going, and it has a very close relation with the third molar, the wisdom teeth in the lower part. During the extraction, it might be traumatized, and the patient will lose the sensation of the anterior two-thirds of the tongue. So it's important to know this passage. And this is the buccal nerve. Buccal nerve, which is branch of the mandibular, is pure sensory or fiber, which is innervating the skin and the mucous membrane of the cheek region. It doesn't have any motoric branch for the supplying of buccinator. Buccinator is innervated by buccal branch of facial nerve again and again. Auriculotemporal, I said it's very important for the not only the sensitive innervation of this area, but also it has the postganglionic parasympathetic fiber from the ganglion, otic ganglion, for the innervation of the parotid gland mainly. And lingual nerve is sensitive, we already said. And here is the submandibular ganglion. So again, for submandibular ganglion, the root is facial nerve. The branch of facial nerve is chorda tympani. The nucleus is the superior salivatory nucleus. And the chorda tympani, it gives the taste fiber and the parasympathetic fiber to the lingual nerve. So here, as you see, is a chorda tympani. It's going through the middle ear, is going through the petrotympanic fissure, is going and is passing and is joining to the lingual nerve. And now lingual nerve, it can give the parasympathetic to the submandibular ganglion, synapsing, and postganglionic is innervating the submandibular gland and sublingual gland. So this is one. The otic ganglion, the parasympathetic root is glossopharyngeal nerve. Nucleus is inferior salivatory nucleus via the tympanic nerve, and tympanic nerve, it's innervating, the tympanic nerve is innervating the middle ear, and from the middle ear is coming out from the tympanic plexus, it's coming out lesser petrosal nerve, and it's going to the otic ganglion as a Jacobson's anastomosis here. And then here, the auriculotemporal nerve is carrying the postganglionic parasympathetic fiber of the parasympathetic fiber to the parotid gland for the secretion of the parotid gland. And the mylohyoid, we said, it's the mixed nerve. It's supplying the anterior belly and mylohyoid muscle, and also it's supplying the submental region, the skin of the submental region. Dental plexus, we said it. Mental nerve is the pressure point or palpation point for examination. It's innervating the mental region. Here, the skin, labial, the inferior lip, and the gingival part. Clinically, there are a lot especially for dentistry. We have trigeminal neuralgia, is one of the most painful disease in a human being, one of them. For example, cancer of pancreas also is painful, but trigeminal neuralgia, we have essential or primary or idiopathic or secondary, which is usually is one of the branches of the trigeminal nerve. It's under the compression it's happening. It can be via the growing of the tumor. It can be via the aneurysm of the vessels, or any reason that is going in confluence between one of the branches of the trigeminal nerve. The patient will come. This is the state exam question for the dentistry student. So the patient will come to the dentist and they said that I have a lancinating pain it takes a few seconds till 2 minutes it can take. It has a very, very severe pain in area of one of the branches of the trigeminal nerve, or it can be 2 or 3 in rare case. And the dentist must be excluding the dental etiology. So he has to check up if there is a caries or if there is a pulpitis, abscess or something. And if you see that everything is okay, the teeth is okay, so then you will send it to the CT scan or MRI to see if there is a confluence of something pressing some branch of the trigeminal nerve, which is the secondary trigeminal neuralgia. This pain is that much severe that some people, they quit suicide. They cannot tolerate this pain. So that's why it's very important to recognize the reason, and treatment is via carbamazepine, is a drug medication or some operation. So this is application of anesthesia in first semester. I said the place of the application of anesthesia to the mandibular foramen, inferior nerve block, infraorbital, mental, and so on. Facial nerve, 30 minutes. Now we are closing to the interesting nerves. Till now it was a joke. Facial nerve, as you know, and we said, it's exiting from the brainstem at the place of the cerebellopontine angle, together with the vestibulocochlear nerve, and is a mixed nerve. It contains somatomotoric, or according to our classification here, I would mention that is branchiomotor fiber. In some book they write it. Here you can correct it according to our original lecture, a beginning of introduction lecture, so branchiomotoric fiber. The nucleus is called origenis nucleus or motor nucleus of the facial nerve, is the multipolar neurons, and this facial nerve, whenever we talk about the facial nerve, it means we are talking about the motoric part, the branchiomotoric part of the facial nerve. Yes? A little bit is complicated because parallel with the facial nerve, you will hear another nerve, which is called intermediate nerve. Here, intermediate nerve. And this intermediate nerve, as a matter of fact, is a part of facial nerve, but it contains the parasympathetic fiber and it contains the taste fiber and another fiber except the motoric fiber. So to understand, facial nerve is general, yes, but this facial nerve, we divide them to the real facial nerve, which is only contain the motoric fiber, mainly for the innervation of the muscles of the facial expression or mimic muscle, and intermediate nerve, which is, as a matter of fact, inside the facial nerve, but we say it intermediate nerve because it's between the facial nerve and vestibulocochlear nerve it passes. And it contains parasympathetic fiber and taste fiber and sensory fiber. So, facial nerve, as you know from the first semester, contains taste fiber for the anterior two-thirds of the tongue, for the taste innervation. It means taste innervation is a special sensory. And the nucleus for the taste is very important, is the cranial part of the nucleus, which is called solitary nucleus, and a specific part for the above this solitary nucleus, there is a nucleus which is called gustatory nucleus. Gustatory nucleus is the origin for the taste fiber for cranial nerve number 7, 9, 10. And location is in the cranial part of the solitary nucleus. Contain parasympathetic fiber, oh my God. We already said that the facial nerve is responsible for the parasympathetic route of pterygopalatine ganglion as a branch which is called greater petrosal nerve, and for the another parasympathetic ganglion which is called submandibular ganglion, which is via the branches of chorda tympani. So the facial nerve is the only nerve that takes or gives two parasympathetic route for two different parasympathetic ganglion. One via the greater petrosal nerve to the pterygopalatine ganglion for secretion of the lacrimal gland, nasal gland, palatine gland, soft palate, hard palate, tonsillar gland that we said that ganglionar branch of the maxillary nerve. And another branch, chorda tympani, responsible for, which is closing to the lingual nerve. I have a love story for that, but later I will tell you. Is giving its taste fiber and parasympathetic fiber to the lingual nerve and to the submandibular ganglion for the secretion of submandibular gland and sublingual gland. So the nucleus, the parasympathetic nucleus of the facial nerve is the superior salivatory nucleus. Here, don't forget this name. Superior salivatory nucleus is the parasympathetic nucleus. Another name also is, you can use it, dorsal nucleus of the facial nerve. Whenever you say dorsal nucleus, it means the parasympathetic nucleus. Yes, but it has a specific name. Usually, we know it as a superior salivatory nucleus. Inferior salivatory nucleus, just open, is a parasympathetic nucleus for glossopharyngeal nerve. Don't confuse these two names. Superior for facial, inferior for superior. The branches of the facial nerve, we divide them to two parts. The branch inside the facial canal and the branch which is outside of the facial canal. Somatomotoric function, we said that is for the innervation of the mimic muscle, and also the stapedius muscle of the middle ear. The damage of this nerve to the stapedius, it can cause the pain when you are talking with the mobile, so your mobile must be there. So it's called the disease which is called hyperacusis. So the balance of the vibration of the tympanic membrane, it's disturbed. So this is called hyperacusis. This is a disorder by the paralysis of the nerve to the stapedius. Posterior belly of the digastric stylohyoid and via the otic ganglion, via the branches of the trigeminal nerve is innervating the tensor tympani. That is a little bit complicated. Visceromotor is a parasympathetic. We already said it's innervating those glands and two branches of the, and you see here is the intermediate nerve or nervus intermedius. Whenever is not motor is the facial nerve. Whenever is visceromotor or taste is intermediate nerve, we say. Is innervating the lacrimal gland and nasal cavity, paranasal sinuses, and so on via pterygopalatine ganglion, via the greater petrosal nerve of the facial nerve, supplying these two glands, sublingual and submandibular, via chorda tympani, which is connected to the joining to the lingual nerve for secreting of these two glands. And of course, floor of the mouth and anterior 2/3 of the tongue, a small salivatory gland. Here I wrote it, the details about the another fiber, somatosensory fiber, which is the fiber which is located inside the geniculate ganglion. Is contained the pseudounipolar cells, and the course, you know it through the skull. It's going to the internal acoustic meatus, to the upper anterior quadrant, the area of the facial nerve. Then it's going anterolaterally, then it's turning posterolaterally. In this transitional place, there is a geniculum or genu of the facial nerve. Be careful, we have two genu, is turning of the facial nerve. One is internal, is inside the central nervous system. When the motor nucleus of the facial nerve, the motor fiber is turning around the nucleus of the abducens. This is called internal genu or internal genu. Another genu is external, is outside. the place inside the fascial canal between the anterolateral and posterolateral course of the fascial canal. And in this external genu, the fascial nerve, it gives the greater petrosal nerve that already we discussed it. Inside the canal, it gives greater petrosal nerve. We already discussed it. It gives, this is the greater petrosal nerve. It's the place of the genu. Then it's the posterolateral part, and then there is a descending part. And descending part, it gives nerve to the stapedius muscle here, the smallest muscle in your body, and is pure motor. And damage, it can cause hyperacusis. And here is the our princess nerve chorda tympani, which is passing through the canaliculi of the chorda tympani, and it's emerging of the skull, it going to the middle ear and emerging of the skull through the petrotympanic fissure. And it contains taste fiber for anterior two-thirds of the tongue, and parasympathetic fiber for submandibular ganglion. Again and again I'm repeating, which is very important. Here is the stapedius, cause hyperacusis, chorda tympani, we said it. Those are the branches of the fascial nerve inside the canal. So recapitulation, inside the fascial canal, fascial nerve has 3 branches: greater petrosal nerve, nerve to the stapedius muscle, and chorda tympani. Then it coming out of the stylomastoid foramen, it gives, before it enter to the parotid gland and it's making intraparotid plexus, it gives posterior auricular nerve, which is a mixed nerve containing somatomotor for occipital muscle and posterior auricular muscle. And it has somatosensory for innervation of the skin of the lower part of the auricle and external acoustic meatus. Then it gives nerve directly to the posterior belly of the digastery, because anterior belly is innervated by mandibular nerve. It gives directly branch to the stylohyoid muscle, and then it enters to the parotid gland, is making an intraparotid plexus, and it gives 5 branches: temporal, zygomatic, buccal, marginal mandibular, and cervical for mimic muscle and platysma. So those are the chorda tympani, how they pass, stapedius, chorda tympani, million trad, we said. Here is the branches of the fascial nerve for the mimic muscle, for the branches. Remember, the ramus coli or cervical branch is innervating platysma. Yes, platysma. The rest is innervating this muscle, the frontal part of the epicranius and auricular muscle. To remember, if you put your hand in the region of the parotidomasseteric muscle, so the direction will guide you to remember the name of the branches: the temporal, zygomatic, buccal, marginal mandibular, and cervical. Yes, the marginal mandibular is important branch here for dentistry. Remember forever, you never cut anything here in this region with the scalpel, because here superficially it passes marginal mandibular nerve. If the patient has abscess, you go 2 centimeters below the margin of the mandible here. Always the cut, it must be here. Even the pathology is here. Why? 1, fascial nerve is, fascial artery is passing here. If you cut it, bleeding happen. Second important, marginal mandibular nerve is passing here. And if you cut, you will reach to the pathology, you will reach to the abscess, but patient for whole life will be like this, because the mimic muscle is paralyzed. So remember forever. And the lesion of the fascial nerve is very important also. We have the central region and central region and the peripheral region. The central region, or lesion, sorry, it's central palsy is called. It's very, very important. Just pay attention. The mimic muscles of the face, we divide them to the upper part of the mimic muscle and lower part of the mimic muscle. Yes? The upper part of the mimic muscle of the face, as you see here, those are the place of the central nerves that they are controlling the innervation of the upper part of the face. And they are from one side of the brain, it's going to the same side, and it's going to the contralateral side, opposite side. So it means that the upper portion of the face is taking the control from the brain, from the same side, and from the opposite side. So if I get the brain stroke, and one of the center here is damaged, yes, the other center is working, and my upper part of the face still is working, yes. But interesting is lower portion of the body. Lower portion of the body, the mimic muscle, if you continue here, they are always crossing. So it means that the right side of the brain is controlling the left lower muscle, and the left part of the brain is controlling the right lower muscle of this. And we don't have contralateral, yes? So if there is a damage, brain stroke, they call it wake-up ischemia. It means that the patient will wake up and he got the brain stroke. What will happen? The angle of the mouth, it will be down. Yes? This is the first sign of the brain stroke. Yes? So, because there is no contralateral covering of the lower face of the body. If there is a central palsy, if it is peripheral palsy, then the same place in which level the facial nerve damage, so the symptom is appear for upper part and lower part. Yes? So there is a difference between the peripheral part and the central palsy and peripheral palsy. The peripheral palsy is called Bell's palsy also. That sometimes you can see in some patients. Oh, vestibulocochlear nerve, it's for 1.5 hour talking. So because it's a part of the central nervous system and the pathway of central nervous system, I think Professor Ferda will lecture you. I just write for you some information that extremely can be helpful for you, because me myself, when I was a student, maybe 20 times I have to read it to understand what is the pathways working for the hearing and this thing. So this is the simplified of this. I just showing to you as it's recording to have it for you, and definitely we will have it in the lecture, or I think maybe he said it in the ear part. Yes, this is the vestibulocochlear nerve. I just passing quickly. Those are the information about the vestibular nerve, how the pathway is originated. Of course, you have to know the cochlear part is responsible for hearing, vestibular part for the posture. There are the receptors that they are located in the utricle and suckles and semicircular canals as a macula statica, and here the macula statica and the ampullar crest here. And these receptors, they are responsible, or they are sensitive for the motion, and they go to the bipolar cells or bipolar neurons that they are located in the vestibular ganglion, which is located in the internal acoustic meatus, and then it goes to the nucleus. Remember, the vestibular nucleus, there are 4: superior, inferior, medial, and lateral. And from the nucleus, they go to the different part of the central nervous system. For example, cerebellum. For example, the vestibulospinal, it going to the spinal cord to contract the postural anti-gravitation muscles of the lower limb. So it's taking you in the postural position, yes? And different pathway, medial vestibulospinal, lateral spinal, vestibulospinal, vestibulocerebellar, vestibulocerebral, and vestibuloautonomic pathway. So this is the thing. And here you can see this ampullar crest and suckle and utricles that they are the macula statica is located. Here is going to the ganglion and is going to the four nuclei. For hearing, The ganglion is located in the cochlea, in the spiral portion of the cochlea, and the hair cells, they are responsible for the detection of the impulse of the endolymph is the organ of Corti. Organ of the Corti or spiral corda is going to the bipolar cells in the spiral ganglion or cochlear ganglion, is going as a tractus foraminis, and it going to the nuclei. Remember the cochlear nuclei, there are two nuclei, ventral and dorsal, and then there is a pathway. Here it's again, you have it, how the sound, it goes through the external ear, middle ear, and to the inner ear, is going to the ganglion and is going to the cochlear nuclei, which are ventral and posterior and dorsal. And then how they are crossing over, remember of the lateral lemniscus. Lateral lemniscus is a part of the hearing pathway and is interconnected with the inferior colliculus, is the hearing pathway, and it's connected to the medial geniculate body. Lateral geniculate body, remember, it's optic pathway. Medial geniculate body is the hearing pathway. And the area of the perception of the hearing is in the temporal lobe of the brain, which is, according to the Brodmann area, is 41, 42. Very famous is the transverse temporal gyrus, is the Heschel's gyrus, is 41, 42. Lateral system, 10 minutes. Lateral system is not used, this terminology, in English textbook, but 9, 10, 11, they have in something common. So that's why in some literature there are these three nerves, they are saying or discussed together. Why is together? So those are the mixed system, they call it, and is located in the retroolivary part, especially 9 and 10, and 11, of course, the cranial part. And they contain the mixed fibers. This mixed fiber, it means that somatomotoric fiber, the nucleus is called nucleus ambiguus. It contains the parasympathetic fiber, but the nucleus is different. For vagus or vagus is the dorsal nucleus of the vagus. For the glossopharyngeus is the inferior salivatory nucleus. Again and again is via the tympanic nerve, tympanic plexus, lesser petrosal nerve, Jacobson's anastomosis to the otic ganglion, cranial nerve number 5, to the auriculotemporal, after the synapsing, the postganglionic fiber, to the parotid gland. Vagus is the largest sympathetic. It doesn't have a specific, it has a ganglion, it has a several ganglion, but in their pathway, they don't have a specific name, and is responsible for the parasympathetic innervation of rest till the left colic flexure. So this is the glossopharyngeal nerve that, as we said, these are the emerging in the retroolivary place, contain branchiomotor fiber for the muscles of the soft palate and together with the vagus muscle of the pharynx. It contains parasympathetic fiber, inferior salivatory nucleus. It contains viscerosensory fiber. It means that the sensation for the organs is the innervation of the pharynx, posterior 1/3 of the tongue, middle ear, and auditory tube. It contains the taste fiber. It means gustatory nucleus for the posterior 1/3 of the tongue. So here is almost the same things that we said it, that it's the, again here is giving the tympanic nerve, which is going to the otic ganglion via the auriculotemporal, is innervating the parotid gland, is innervating the glomus caroticus or carotid body, which is the chemoreceptor, and the carotid sinus. Here is the glomus or body, is the chemoreceptor in the bifurcation, and in the beginning of the internal carotid artery is the carotid sinus. It's baroreceptor or pressoreceptor for the blood pressure. is innervated by the glossopharyngeal as well with the vagus. And also then it continue innervating the stylopharyngeus muscle. Whenever you want to find the glossopharyngeus nerve, you will find a stylopharyngeus nerve. Whenever it goes, it goes. And then it goes to the tonsil as a tonsillar branch, and it gives the lingual branch for the innervation of the posterior 1/3 of the tongue or root of the tongue. This is the recapitulation of these things that we said it and the fiber that it has. And it has tympanic nerve. We said it for the tympanic cavity already in the middle ear. You had it, the test of the middle ear. It gives of a stylopharyngeus nerve. It gives pharyngeal branches together with the vagus. It gives for the carotid sinus and carotid body. Chemoreceptor, baroreceptor. It gives tonsillar branches, and it gives the lingual branches that already we mentioned it. Here is the recapitulation what we said. Here is just showing you the tympanic nerve, which is going through the fossula petrosa to the promontory. It's making a tympanic plexus, and from it's taking a sympathetic fiber from the caroticotympanic nerve, very important nerve, from the superior cervical ganglion to the internal carotid plexus. And here is the lesser petrosal nerve, which is carrying the parasympathetic fiber and the rest of the fiber to the otic ganglion. Yes, here is things in here. Those are the things that we already said about the glands of the carotid sinus and so on. Examination. If there is a damage of the glossopharyngeal nerve, because glossopharyngeal nerve is supplying the soft palate, and ovula is one of the muscle of the soft palate, so it's a paired muscle. Usually is in the center. When the patient say ah, so you will see that it's hanging in the midline. Yes. If there is a damage of the glossopharyngeal nerve, it means that that side it will be damaged and is paralyzed of one side of the ovula. So the healthy one, which is working, is catching the ovula toward the healthy side. So the deviation of the ovula, if there is a affected side in the left side, so the deviation is going toward the healthy side. So then when it's not in the center and is going to the deviation one side, so there is a nerve palsy in the opposite side. Yes. If it is again central, is in the contralateral. If it is peripheral, is the same side. Vagus. To be easy, it contains everything. Everything. So branchiomotor nucleus ambiguous, parasympathetic dorsal nucleus of vagus, viscerosensory the solitary nucleus, taste fiber gustatory nucleus, exteroceptive or somatosensory, it's going to the spinal nucleus of the trigeminal nerve. It has a connection with the trigeminal nerve. Largest nerve, those are the same thing that we said, is the largest parasympathetic nerve, cranial nerve, which is not only in the head and neck region, but it's going to the neck region, it's going to the thorax, to the abdomen, and it's ending to the left colic flexure. It's giving the meningeal branch, auricular branch, it's giving the content of the carotid triangle, content of the carotid sheath for 1,000 times. Remember, content of the carotid sheath. Laterally internal jugular vein, medially common or internal carotid artery, between them dorsally vagus, anterior to that descending branch of the hypoglossal nerve. So it gives the pharyngeal branch together with the glossopharyngeal nerve, carotid sinus, carotid body, the same things. It giving the superior laryngeal nerve, branch of the vagus, that we said it in the larynx part, that it gives external and internal. It gives its superior laryngeal nerve, it's only nerve that is innervating one muscle of the larynx and is the cricothyroid muscle. This is the external. Internal branch is the sensory and is supplying the mucous membrane of the larynx from upper part till the level of the vocal cord. And very, very, very important nerve, recurrent laryngeal nerve. It's the nerve that is a branch of the vagus. Be careful. It's turning in the right side around the subclavian artery. In the left side is around the arch of aorta, is crossing the ligamentum arterosum. And then recurrent, it means that it's going back to the neck region. And where you can find it? Between the trachea, the fissure between the trachea and esophagus. So here is the posterior aspect of the trachea. Here it must be esophagus. And here is the recurrent laryngeal nerve. It's both sides. And you see it has a close relation with the thyroid gland. So the doctor or the surgeon, after the operation of the thyroid gland, during must extremely pay attention to not to cut the recurrent laryngeal nerve, because it's innervating motoric, all the rest of the muscle except muscle of the larynx except the cricothyroid, and the sensitive innervation as an inferior laryngeal nerve below the vocal cord. Very, very, very important nerve, recurrent laryngeal nerve. Also then, the vagus is going to the thoracic cavity in the posterior mediastinum. Right vagus is going behind the esophagus. Remember, right, when you go to, for example, WC, right is going behind, left is going in front. Yes, they are making right side posterior vagal trunk, left side it's making anterior vagal trunk. They're going parallel with the esophagus, they make esophageal plexus. Then it enters through the outside from the diaphragm as an esophageal opening, and then it's making the esophageal gastric branches. It gives the hepatic branches, celiac branches, renal branches, and is finishing in this cannon beam points, which is in the left colic flexure, which is territory of the vagus, is finished. So vagus, give me, please, can you give me 5 minutes more to finish it? Yes? Do you have any lecture now? Just 5 minutes, I just finish it to have this material because it will be very simplified for you when you study. Accessory nerve is exclusively is a branchiomotor nerve. In the beginning I mentioned it has two parts, spinal part, or a spinal root, which is originated from C1 till C6, some books 5, some books 6. And it's going from the lateral aspect of the anterior horn, and they join together and they make the spinal root, which is entered to the skull through the foramen magnum. So this is a spinal root or a spinal part. Accessory nerve has another part which is called cranial part. The origin is nucleus ambiguous, the same that you had it in the vagus and glossopharyngeus. And this is called cranial root. These two roots, the cranial root and a spinal root, they join together and they make accessory nerve. This accessory nerve then is coming out of the jugular foramen. Yes, as you know, jugular foramen in ventromedial part, we have the 9, 10, 11. Yes. Interesting is divided immediately to the internal branch and external branch. Internal branch is carrying the fiber from cranial root, and immediately after it's coming out to the jugular, from the jugular foramen, is going to the vagus nerve and is going to the recurrent laryngeal nerve. So, as a matter of fact, the muscles of the larynx, except the cricothyroid muscle, which is supplying by the superior laryngeal nerve, the muscles of the larynx, which we said it, that is innervated by recurrent laryngeal nerve, the origin of the origin, it's from the cranial part of the accessory nerve, from the nucleus ambiguous. The spinal part is responsible for innervation of two muscles, sternocleidomastoid muscle and trapezius muscle. Yes? So these two different, the internal or cranial part is responsible to go to together with the vagus for the recurrent laryngeal nerve, and internal one is this. You can see it here. This is the spinal root, which is then it's going down as an external branch for innervation of the sternocleidomastoid and trapezius. And here is the nucleus ambiguus, the cranial root, which is making the accessory nerve is coming out of the jugular foramen, but is joining to the vagus. It's going to the recurrent laryngeal nerve for innervation of muscles of the larynx. And the last thing is hypoglossal nerve. We already said it in the first semester in tongue region. That is an exclusively somatomotor nerve. It's in the preolivary sulcus, and it's giving the innervation for all the muscles of the tongue, intraglossal muscle of the tongue, and all the extraglossal muscle of the tongue, except the palatoglossus muscle, which is the muscles of the soft palate, as well consider. All this information, you have it in the first semester lecture that I said about the tongue. And also, I said about the suprahyoid and infrahyoid muscle that is innervated by deep ansa cervicalis. Deep ansa cervicalis is formed by the descending branch of the hypoglossal nerve or superior root of the ansa cervicalis, superior root of the ansa, which is carrying the fiber from C1 or C2, and inferior fiber is carrying from C2, C3, and they make the ansa cervicalis for the innervation of the infrahyoid muscle, except the thyrohyoid muscle, which is innervated just from the C1 itself. Two muscle is carried parallel with the hypoglossal nerve, which is carried and innervated by the C1 spinal nerve, and those are the geniohyoid and thyrohyoid muscle. We said it in the suprahyoid muscle as well in the lecture, yes? And otherwise, for example, it's supplying the all intraglossal muscle or intrinsic muscle, and all extraglossal or extrinsic muscle except the palatoglossus. And the last things that I wanted to say, one of the routine examinations in general medicine and dentistry, if you want to check that the glossopharyngeal nerve is okay or not, so you ask the patient to protrude the tongue. If there is a damage in the left side, what will happen? The tongue is deviated to the side of the damage. Yes, because the right side is much more stronger. When we want to do is pushing the tongue toward the paralyzed tongue. If both of them is symmetrically working, the tongue is in the midline. Yes, so but if there is a damage, so it's going to the opposite side. So deviation to the opposite side. Again, you have to consider if it is central palsy or peripheral palsy. If it is central, it's crossing from the brain. If it is peripherally, it's ipsilateral function. Oof. Thank you for your attention.